Hello, everyone. I'm Dr. Darsh Shah,
And I'm Dr. Altamash Raja,
and welcome to Medicine Redefined.
a podcast where we will explore the often overlooked but necessary components of health, what we consider to be the fundamentals.
We will investigate topics and practices that can give you and your patients the best chance to optimize a healthy lifestyle. It's time to move the needle forward and put the health back in healthcare.
Welcome back to our Part 2 discussion with Dr. Jonathan Baktari. As promised, in this episode, we discuss the intended topic for our first discussion, and that is all things digital health. So here we'll touch on the current role of digital health in medicine as we practice now. We talk about the foundational limitations for incorporating digital health successfully into the healthcare model, where and how we would start to optimize the system using digital health, and we spend some time talking tactics on what a bright future with a robust and efficient digital health system looks like that emphasizes patient care and quality. As a successful entrepreneur, Dr. Baktari shares insights and lessons that he's learned in building a successful company that is completely digitized. Lessons that we may be able to use to build an efficient mousetrap, as a previous guest, Dr. Chris Standard, once said. As a reminder, Dr. Baktari completed his undergraduate studies at Case Western Reserve and went on to get his medical degree from Ohio State University. Subsequently, he did his internal medicine residency at Northwestern University and a fellowship in pulmonary critical care at UCLA. Now, without further delay, please enjoy this discussion with Dr. Jonathan Baktari.
Dr. Jonathan Baktari, thank you so much for coming on for Part 2 of the podcast.
Oh, thanks for having me. Big honor.
Yeah, pleasure's ours. Not too long ago, we were here screen to screen talking about Part 1 of our show, right? And that was about travel medicine, COVID-19, what we can do to prevent another epidemic like this one just happening. And it wasn't originally what we wanted to talk about in the first place, right? What we wanted to talk about is what we're going to be talking about in today's episode, which is going to be digital health. But we still had a fantastic time. And so for all the listeners here that are new to Part 2, highly recommend checking out Part 1 and just really learning about new topics that really aren't taught in medicine and aren't talked about enough. So we're definitely excited to touch on today's topic with you, which again is going to be digital health. So why don't we just start with the basics, talking about what exactly digital health is and what it means for our healthcare system in the current moment.
Yes, oh, that's a great question, because digital health from a satellite perspective is really getting the right information about patient care, patient data, to the right people, all the right players in a way with minimal friction when they need it, sort of on-time delivery of critical information about patients, whether it's from the pharmacy, other doctors, other providers, which has been a barrier in medicine for decades. Really, I can think of very few things that has in the past negatively impacted patient care than having the right information at the right time. So that's the whole idea of digital health, to overcome that problem.
And so what are some common examples for, maybe the layperson in terms of how we're incorporating digital health into our current state of practice?
Well, let me just preface it by saying we're not there. I mean, we're not there yet. We're not in optimal digital health, because some of these problems still exist. But in a utopia, obviously, and I think the one thing that patients can often relate to is when they see multiple doctors. Very few often know what happened at the other doctor visits. It's not uncommon for a patient to come to see the primary care doctor and say, well, I saw the cardiologist and he said there was nothing wrong with me. I don't know if he really said that. Let me look up his records. That ability of physicians to understand what other physicians or other providers or what the speech therapist said or what the dietitian said, and whether, often just understanding what you're being prescribed by other people, what kind of diagnostic tests have already been ordered. And then the redundancy, in my day, it was very uncommon for every doctor to order his own lab tests, and I never see the lab tests of other doctors, and even within the hospital to see what other providers are thinking, what is the physical therapist thinking. This added information often really changes your perspective on certain situations when you're there. If only you knew that information. And it goes even beyond that. Previous hospital admissions, how difficult is it to get those records? What tests has already been done? Hospital stays at different hospitals that, wasn't this hospital. If we had all that information in real time, it could only improve decision making.
I find it interesting that you're saying we're not quite there yet. So I think to maybe give an example to some of the trainees who are listening, and then also the patient side. So I'll use the physician side first. One of the largest EMRs in the country is Epic at this time, right? And so anybody who uses Epic across multiple systems, different systems that are using Epic, it can communicate with each other, and you can see the different labs that you're talking about, different test results, consultation notes, et cetera, et cetera. And so if you're an institution in South Jersey versus in Pittsburgh, you're using that, there is a way for you to look at all the records for somebody who got care everywhere. That's kind of what you're talking about. On the flip side, the patient side, a lot of patients have this system called MyChart. It might have a different name, but that links to the provider notes, your test results and stuff. And then if you go to different institutions, you can link all your MyChart. Like, for instance, I was in Baltimore, I did my training. And so now when I go into my MyChart, I can see my results from Jefferson, from Hopkins, from Geisinger, which are all, in different areas. That seems to be pretty efficient to me. Yet do you agree that?
Oh, I mean, well, first of all, how about if it's not Epic?
Fair.
Okay, that's the most obvious one, right? And
Right.
how about the speech therapist that you went to see, and how about the rehab center that you sent the patient to? Look, I'm not saying it's not better. I'm just saying it's not there. I mean, nobody should be dancing in the end zone, thinking we're there. We are not there. It is better, but it is not where it needs to be, where all the information that would be relevant to decision making is at everyone's fingertip. I mean, there are barriers because of systems and privacy and HIPAA and what have you, but and even from a patient point of view, yes, we have MyCharts and they have access to that, but I don't think they fully see everyone that's not in MyChart. Now, if you belong to a system, you're the UCLA system, and everyone you see is at UCLA, you're okay probably. But if you decide to, for whatever reason, get referred or go see somewhere else or move jobs or what have you, and you're not in the same system, same ecosystem, do we still have that level of connection?
That's a good point. I think I was probably being a little bit naive there, saying that, and this just kind of goes to show you, when you get stuck in your little silo and you think that that's the information that's accessible to everybody, but it's not. You make an excellent point. Those who are in private practice or smaller group practices who can't afford a large EMR system like Epic aren't going to have that. In fact, I recently had a conversation with, a surgical center that I was looking at, and come to learn that they're not using any EMR and they're doing paper charts, which in 2023, I thought was amazing and incredible. But, as the bottom line, these EMRs, hosting them, technology, that stuff is very, very expensive.
But you know what? It gets worse than that. I mean, to anyone who's listening, okay, you think most doctors or most groups have EMRs. If that's true, when you walk in, why did they give you a clipboard? I mean, the point really is, I don't think it's as easy as you think it is. Okay, if everyone has an EMR, how come everyone's still getting a clipboard?
Yeah.
Well, what is a clipboard? Last I heard, that's not digital. What's those 15 pages that you fill out when you walk in? Everyone, you're smiling because you've been given the clipboard, or you've handed people the clipboard. Okay, don't tell me you have electronic health records and then you hand someone a clipboard. I think we're fooling ourselves. When somebody, like when I tell people, what a blackboard is or what a VHS is, they're like, what is that? When someone says, what's a clipboard with a doctor's visit, we've gotten there, but we haven't gotten there because
I love it.
Everyone's getting a clipboard. I know everyone listening to this has recently been handed a clipboard, and I think we're patting we're patting ourselves in the back, we're dancing in the end zone, but we're not there.
I like that. What about telemedicine, right? Particularly in the time of COVID, there were national changes and guidelines in terms of how you could practice cross state lines, et cetera, et cetera. And I felt, again, like we were getting better at telemedicine. And some of those national emergency has been lifted. And so the rules are going to change by the end of 2023. But where do you put that? Do you not put that in the same bucket?
No, I do. And I think it's great. I think the ability to see, like, let's say I have, kidney stones and it's a problem that's complicated. And I want to see the guy who wrote the textbook on kidney stones at Harvard. Why shouldn't I be able to see him? Right? Why can't I speak to the Michael Jordan of kidney stones? Right? Well, right? I want to talk to that guy. I want to talk to the guy who wrote the chapter, right? And right now, unless you have a lot of money and resources, you can't. So I think telemedicine is amazing. I think now the danger in telemedicine is the abuse. And I think this is probably the pushback that you're probably getting from Medicare and a lot of people, because I see the abuse, get your Viagra or get your this, get your testosterone shot by just calling, getting online with somebody. When it becomes this thing where telemedicine is used simply to bypass the prescriptive authority that you would normally encounter in a true clinical encounter. So I think that's probably, but there are probably ways to mitigate and regulate that. But I think that's where people have a problem, because while you want to see the Michael Jordan of kidney stones, you also don't want somebody to be, setting up shop in a basement and, selling Viagra or testosterone shots or whatever. Why are you guys laughing?
It's just true, right? I think from our perspectives about everything you're talking about, right? I think so. Let me ask you this. At least we've done a good job setting up what digital health is, right? For the listeners to at least understand that we're talking about things of the so-called near future: telemedicine, electronic medical records being combined, seeing providers that we want to. And we've slowly hinted at solutions and problems that we currently have. Healthcare being such a huge industry, a moneymaker, a solution, but also an issue in the US, let's dissect at least what those root causes might be as to why we haven't progressed as far as we should have when it comes to more accessible healthcare. Do you mind just touching on why digital healthcare isn't where it is right now? Is it the fact that we have electronic medical record monopolies and people are just trying to silo their own money? Is it the fact that it comes down to rules and regulations? Is it insurance companies? Is it just the fact that we don't have the technology yet to get to where we need to be? Do you mind just kind of talking about some of those foundational issues that we're having right now that are preventing us from getting to that next level?
Yeah, that's a great question. Great question. Because, if you really look at non-medical technology, like, look at Amazon, for example, 10 years ago, if I wanted to know what I ordered on Amazon a year earlier, I didn't call Amazon. It's all there. Why isn't healthcare technology at least equivalent to Amazon? And I think the main reason for that is because your transaction at Amazon is a two-party transaction. So Amazon simply needs to provide enough technology to make you happy or make you want to use their service. And you will give Amazon your business if they make your life easier and you get what you want. Only two people, it's like being on a date. Whether that date is successful or not is dependent on two people, right? But imagine you go on a date and the chef sits at the table with you for the dinner. That's not you're not going to have the same conversations. It's going to be, you're trying to now incorporate a third person to potentially make them happy, give them attention. Maybe there's certain conversations they want to have that you don't. So really the problem is the transaction. the transaction in healthcare is not a two-party transaction. It's often a third, maybe four parties involved. So one of the interesting things that e-national testing and US drug test centers, where for whatever, because of the nature of the business, we're not involved in insurance companies. When we write code, right, for our software, we're not there trying to necessarily make Medicare, Medicaid, or the insurance company happy or comply with this or that. What we're trying to do is make the patient happy, provide quality for the patient, have their user experience. Let me ask you a question. Let's say you're a software developer, or you have a company that develops software, and you write an amazing electronic health records that's 10 times better than Epic. 10 times better. Okay? It auto-populates everything. It has a better interface. Healthcare providers will spend half the time doing the same work, and patients will have much better access to anything and everything they would want. Okay, so you got that software. We'll call it, Epic Plus. Okay, and you're in front of a CEO of a hospital chain, and you say, Mr. CEO, please look at Epic Plus. We want you to get rid of your Epic and buy our Epic Plus. It's fantastic. It does everything perfectly well, much better than Epic. There is one little problem. Your Medicare reimbursements will go down 5% if you use Epic Plus.
There's no chance.
What do you mean no chance? Wait. The doctors will have to spend half the time. The patients will have everything at their 10 times faster. We could only code for so much. Only certain things could be we put all our priority in making the healthcare provider make better decisions, provide better quality, and make the patient. But with all this Medicaid, we won't be on time with every new regulation, every new update. I could only tell our coders to focus on so much. And this is where we put our back into that. Only 5% less Medicare reimbursement.
Yeah. In the analogy used earlier, the chef gets to make the meal, right? So, and that kind of maybe dictates how the night might go. And that's kind of how it works here. I mean, so that's the fourth party. If you're talking about hospital administration, obviously insurance company is probably the third party, in my opinion. But, unless, I shouldn't say there's no chance. I could certainly see, and this is usually more of an issue in private practice, where they'll say, okay, or if you're going to cut half the time in documentation, then maybe we can see a larger volume of patients, and therefore you can do that on the back end, right? So there's that chance, but it doesn't create better quality care.
But then, so if you're giving the prime directive to your software developers, what's the first 10 things you're going to tell them? Don't screw up the Medicare reimbursement.
Right.
Optimize that. So you're writing code. What are you going to focus on? Compliance, regulation, reimbursement. Of course, third or fourth level is ease of use and patients and what have you. But you should talk to a coder. They can't have too many prime directives in the software. If the prime directive, but Amazon doesn't have this problem. Or, any software, QuickBooks doesn't have this problem. They're not trying to make a third or fourth party happy necessarily, right?
So I'm going to jump ahead a little bit.
Okay.
If we fast forward, what's the fix? Is it consumer driven care? Is it these models of people are kind of just shifting outside the traditional healthcare model? Because I've referenced this book time and time again. Marty McCary, The Price We Pay of the Healthcare, right? We're talking about just the escalation of costs, the healthcare being a bubble. It's the way that we're going. It's, nearly 19% of the GDP. It's not sustainable at all, right?
Well, but then ask yourself this. If you look at government involvement in healthcare last 20, 30 years, what direction is that going? Is there less government involvement or more government involvement in the last 30 years? Is Medicare, Obamacare, Medicaid, are they growing or shrinking as a percentage of healthcare?
think more so, much more.
Yeah,
I mean, although
much.
we just kind of practiced a year ago, so but seems to be a lot more in the even just the last 2 years that I've gotten to learn more about the business of medicine.
Right. So again, I mean, the DMV is not getting any better every year.
I don't know. I was able to renew my license online this year.
Anyway,
I see your point.
okay. Okay, listen, have you been to the post office lately? Have they revolutionized anything?
No.
Okay. The point is government involvement. I'm not saying there isn't a role for government. Of course there is. We need a safety net. We need to have, but by and large, you know, there's a reason why people in Canada and England and what have you, you know, have the experiences they have. The more government involvement you have, the more it will muddy this sort of clarity in terms of progressing with digital health, because you have to make government happy, rightfully so. If we're getting money from them, we got to comply, and they want to make sure their money is being well used. So, but the issue really is, someone could make an argument that the more we expand government into healthcare, the more challenged digital healthcare will be, by definition.
So we are talking about some of the problems, and I'm willing to bet you've given a lot of thought into the solutions. Where would you start?
You're not going to like the solution. The solution is less government in healthcare, but it's just not the way it's going. I'm a salmon swimming upstream. The solution is less government, and now we need government. You know, obviously Medicare is here to stay, of course, and it's great because it provides a safety net. But all things being, I mean, look at Obamacare. I mean, what it's done to, you know, choices for people. You know, it's literally eliminated in most states the option for individuals to get, you know, private insurance. It's literally gotten rid of it. You have, most states you have no option or one option. That can't help. You know, in many ways, what's happening in healthcare, and there's a second component, which is sort of the consolidation from equity groups and what have you, that is compounding it. But look at the cell phone industry 10, 15 years ago. There's 5, 10, 15 cell phone carriers. Now there's 3. They all bought each other up. There are less choices. You know, just when you get off this podcast, call Verizon and see how long the wait is. Okay, or whichever one of the 3 you want to call. Again, same thing happened to the airline industry 10, 15 years ago, 12, 15 airline carriers. Now 3 main ones, maybe. You know, when you get off this podcast, call one of the airlines, see how long the wait is. And you have to pay for your bags, you have to pay for your meal. I mean, what I'm trying to say is, as things consolidate and there's less choices, what can service improve?
No, it's a monopoly.
So when government gets involved and eliminates competition, now they don't allow competition across state lines with insurance carriers. Obamacare basically has eliminated the individual private insurance industry. What could go wrong with that? What could possibly happen when we do that? What could possibly go wrong? Are you getting better service on the airlines than 10 years ago? Has that improved?
Josh, you're the big traveler here.
No, definitely not. Absolutely not. I mean, yeah, maybe they'll kind of buddy up with you because everyone, like you said, Amazon, everyone's trying to be a more customer forward service, right? So I think there's this illusion that we're trying to do that on the front end, but on the back end, I mean, I don't really think that's the case. So I almost took your question as a rhetorical question in that regard.
Yeah. Is your cell phone provider providing you better customer service than 10 years ago?
No, definitely not.
Definitely not. Same thing with credit card company. I tweeted this earlier today, Darsh.
I saw it. Yep.
So what's going to happen when? And then the second problem, which you didn't ask me, but I'll just bring it up, is this consolidation of healthcare, which is, you know, hospital hospitals buying up doctor practices, as well as equity groups and Wall Street buying up different healthcare systems. So there was a statistic that really startled me. I think 10, 15, 20 years ago, 75% of physicians were in private practice and 25% were employees. This year, it's the opposite. 75% of physicians are employees, 25% are in private practice. And that's only going in one direction. So you can only imagine what will be in 5 or 10 more years. So again, this is again from consolidation, Wall Street money coming in, buying up cardiology groups, pain management groups, surgery centers, internal medicine practices, family practice. It's already happened. So it's a rare bird now. In fact, I don't know if maybe you guys have compadres, colleagues that came out at the same time. Do you have many compadres that have gone into private practice?
Very few.
That used to be the opposite. It was unheard of to have a colleague be an employee.
Yeah. Well, let me ask this, Dr. Baktari. So there's a big push for consumerism within medicine. You touched about it offline about how people can now go to an independent lab and draw up an A1C, an ApoB, things that they would usually probably struggle when talking to their primary care doctor. And sure, they might come out of pocket from them, cash-based, more expensive, but they're willing to do it to get more information. How do you see the future of that unfolding? Are you also thinking that these big academic institutions might try to somehow buy up these so-called cash-based practitioners? And by that, we're still improving patient care, right? I think year by year, we're learning more. We're able to prevent more disease. Sure, chronic disease rates are super high, but we're still trying to learn and do our part to get better preventative measures. But do you think there's at least a push to buy up these labs? These practitioners, these labs get cheaper, and thus by default, you have a patient population flocking over to spending less, but still getting the same results, if that makes sense.
Yeah. I don't know about that. I mean, I know there's barriers for doctors from doing it because once you're a Medicare provider, you can't split off your practice and be cash. And so, basically once you sign a deal with Blue Cross or Medicare, you're committed to staying within accepting Medicare and not, can't have a portion of your practice theoretically that's cash based. But if it was arm's length, and I don't know the legality of all that, but I suppose, and then there are a lot of states that have rules against corporations owning that are not doctors or healthcare providers owning practices. So in theory, it's possible. I haven't seen that yet, but in theory, that might be possible. But I don't think they're there yet. I think the companies that are there are so heavily into Medicare reimbursements, Medicaid reimbursements that I haven't seen that yet.
Gotcha. Yeah.
Yeah, I think that's the big issue that is because of the government involvement that he talked about earlier, right? And because of the agreements that you have, you can't kind of have two business models, right? And that crossover, it's almost a violation of doing that, of those agreements. I want to be more optimistic about this. And I think realistically, right, there is, that time is coming, right? It might not be maybe 5 years from now, right? What you're describing 20 years from now when 75% of the people were going to private practice. That's the golden era of medicine we hear about all the time.
Well,
right?
by the way, let me just be clear. There was abuses with that too. So I don't necessarily think that was the golden era per se, because I don't want to come off as this guy who just thinks there was nothing wrong with that system and everything here is horrible. There's a lot of what we can call taking advantage of, ordering unnecessary tests, or, every doctor ordering their own test, not checking to see if it's already been done. Not everyone, but there was a subpopulation. I don't mean it necessarily in a bad way, but that wasn't optimal either. The golden era of medicine had a lot of issues and had a lot of problems. As you can see, I'm an equal opportunity criticizer because I'm in no illusion that was so great. There's a lot of problems with that. Everyone's in private practice, and everyone's kind of getting incentivized. Now there's an incentive potentially to do less, right? HMOs, gatekeepers, and back then, look, human nature being what it was, there was an incentive potentially to do more. That's not good. And it's not good when you don't do enough, and it's not good when you do too much. So I'm not sure. I'm not endorsing the old system. It was ripe for change. We just have to make sure the change we got is better than what it was.
So this might be a bias that we have, like the guest that we have on this, it probably is a bias, right? Because I think if we do step outside of the conversations that we have behind the mics here, then it's much of the issues that you're describing. And that's what we see in day in or day out practice, right? Darsh is still training. He's going to be starting his big attending gig in less than a year from now. And I've been attending a little over a year now. And we see these issues as you're describing. But you brought that point up about the salmon swimming upstream. I think maybe this doesn't quite work that way, but if you have enough of those fish swimming in the opposite direction, at some point that current might change, right? Hopefully. And that would be that bright point, right? That optimistic future that we're trying to get to. And so, we have Dr. Aliyah Gupta come on, talk about direct primary care, right? We have people approaching, talking about remote patient monitoring to help deliver high quality care. How can we do that? And so maybe this is a good time to segue into kind of E7 Health and the platform that you guys have created and how that can help maybe revolutionize, if that's the word you think is appropriate, or maybe augment how we're currently practicing and with delivering high quality care.
Right. Well, our approach at E7 Health has really been to, we have taken the middleman out, not even by our decision. A lot of the services we provide aren't covered by insurance, like travel medicine often is not covered by insurance, employee health, student health. Not all of it, but a high percentage is not covered. And so we are lucky in that sense, because, if you want to call it that, because since they don't cover it, we don't have to necessarily deal with it per se. And so when we write our technology, when we write our software, our goal is to provide excellent care, reduce friction for the patient, and provide them with really ultra fast care, high quality care. And I think we can do that because when we write our technology, when we write our software, we're only focused on quality, reducing friction for the patient and for the staff. And when that's your only goal, when I talk to my software developers, it's a lot easier because they're like, oh, no government regulation, no this or that. And look, I think if you go to E7 Health's website and read our reviews, I think we have 10,000 positive reviews in the past 3 years. And I'm not saying that in a boastful way. I'm just saying, I think the reason why we get so many positive reviews is people can't believe we exist. They just can't believe that, this is so like Amazon, just go click a couple of buttons, you get an appointment, you upload everything, there's no clipboard, you get an iPad, you walk into your car and everything we did for you is on your patient portal. No one even pushed it there. It's just there. And I think they're fascinated by that because it's unlike any other experience. Even on Google, I think we have 1,000 5-star reviews. And I think that's not a function of, I have amazing staff, first of all. They are amazing. They're sweet and kind and professional. So that I have to give kudos to them. But beyond that, I think what these reviews are saying is we want this. We want this to be like Amazon. We want to just get what we want and not have a 3-hour wait in the lobby and not take 6 weeks to get an appointment and not have the results of what we did immediately in our portal. And so I see the craving and the thirst. Literally, if you get a chance to look at our reviews, they all look like they were written by the same person. It's all 10,000 reviews that quick, friendly, fast, different versions of quick, friendly, fast. Thank you, whatever. And that tells me, that there's a thirst for medicine to be like that.
So let's get tactical for a second, right? I think that clearly what you're highlighting is the good business model, right? As long as we can eliminate the middleman, right? And you have that two-person interaction that you spoke about earlier, things you can just focus on what's important, right? Efficient, high quality care. If others want to kind of emulate a business model such as that, and maybe I need to qualify why I'm a little bit more optimistic about this, right? Look, as crass as this sounds, I think some of those antiquated philosophies that we have, right, whether it's at the government level, wherever the policymakers level, at some point those people aren't going to be there because their time has passed, whether it's on this earth or just they're not going to be in office anymore, right? The next generation of physicians or just leaders, right? It's millennials, it's Gen Z who've been having these conversations at a younger time in their life, right? In their early teens, 20s, 30s and stuff. They're going to be in office and they're going to be help generating the new policies. So at some point, I do think it's going to happen, right? So and until then, it's going to be grassroots. And so in the interim, though, people such as us, maybe Darcy, are coming out of practice, right? We need to figure out what can we control, right? Are we going to take agency of our own way that we practice? If you have the luxury to be able to do that, if you're not hamstrung with student loans, et cetera, and financially all that stuff, that all makes sense. Well, this right here, this is something that I give a lot of thought about, right? And so I'm curious to get your take on what might be some tactical things to think about if somebody wants to start up a digital healthcare startup like this, and like what might be some ways that they can scale that to deliver that high quality care we keep talking about.
Well, with digital health, again, you got to navigate, the big question you have to ask is, is this going to be insurance government included or not? Because that really is the fork in the road when you're developing
Let's say not.
technology.
Let's say not, because we've identified that is a big barrier. So let's say not.
Yeah. I mean, the opportunities are endless because then you're as good as Uber, you're as good as anybody else. I mean, I don't think Uber or any other technology has a monopoly on great developers, right? I mean, you have access to those same people theoretically. And so we like sometimes we come up with features in our software that I can't even believe, we came up with it because it just makes so much sense. And so what happens is on a day-to-day basis, when we see a problem, occurring, we come up with technology solutions to address this problem. There was a period where we had a problem where people coming to our offices were bringing children that they were taking care of, little children. And those little children often we have very small rooms, and it prevented the staff from really doing what they needed to do. And this really disrupted the flow. But then my staff didn't want to be in a position to tell them, well, your 2-year-old can't come in the room with you. And so we didn't want to do that either. So we came up with a technology solution where when they're booking the appointment, there's a pop-up, it says, it doesn't totally get rid of the issue, but it says, that you understand that you can't bring little children to the appointment because of the way, and then children scream sometimes if they see someone getting a shot and whatever. So however we came up with a technology solution to even deal with that because the staff was getting stressed out by it, and so whatever the problem is, if you're not, you can focus on the minutia that impacts patient care and quality. We realized, for example, that patients, needed to be scheduled out a certain amount of time. So we literally put into our software that blocks an earlier appointment than let's say you shouldn't be back for 6 weeks, depending on what vaccine or service you got. Our software blocks the person from trying to book an earlier appointment and gives up a pop-up. I mean, we're focused so much on 100 other things to improve quality so they don't come for a visit and are turned away. And there's so many problems you can address in your technology if you can focus on that and not other things. Does that make sense? I mean, I just randomly gave two things that came to thought. There's more, but there's.
It does. It does. But, as you're saying that, I'm thinking about, as we go through medical school, we go through our training, something that I got from one of my colleagues who's a gastroenterologist, and we were talking about just what it's like to actually be in practice, and something he said, he's like, man, we're in the customer service business.
You're
right, and we like that's what we do, and you have to do a good job at that, and because that's what it is. I mean, and I'm not even accounting for different systems reimbursing you or checking your value depending on the reviews and the ratings and et cetera. I'm just talking about just giving high quality care, rather, excuse me. But as you're describing this to me, it almost seems like maybe marketing isn't as important, right? Like marketing yourself, marketing your service. What's the most important, like ground level, that we need to think about is starting with a tech guy, right? Is how to make it as efficient, as seamless, as aesthetic as possible to just streamline everything else that's going to come, all the other issues. Is that fair to say?
It is, but I don't think that's the conversation that happened this morning at Epic. They didn't wake up this morning and say, they got up and said, can I bash Epic? They got up this morning and said, what can we do to squeeze out a little more money from Medicare? So we can, and no, I mean, and justifiably. So I don't mean like in any wrong way, but just to maximize documentation. And look, I'm not saying you can't walk and chew gum at the same time. I'm just saying they're priorities, but it's not as high as. And by the way, compliance is so important. You want to comply with regulation. I don't blame them. And you want to comply and provide, you don't want to get down coded and, unnecessarily. You want to truly represent what happened. Now you have the whole scribe industry. I mean, where did that come from? I mean, obviously part of that was to comply with some of this stuff, which is fine. But it's an issue, and I'm not poo-pooing regulation. I'm not poo-pooing that, but what you described, I wonder if that is really super high priority. I know it's a priority. Look, I don't think any software company wants to have bad user experience or wants to give more work to the doctors or to the patients, but there are trade-offs you have to make as you're writing the software.
So, Dr. Baktari, when you thought of E7 and the mission and the vision that you had, what were your initial conversations with yourself when you thought about the type of services that you wanted to provide, right? Because I think it's important to understand who's behind the project and what their vision is, right? I think, as Altamash alluded to, a lot of the millennial and Gen Z, the way that they view work comes from more of like a passion base, right? And we like to hop around and really figure out purpose and how we can make a difference. So from your perspective, when you were, from the inception of E7, what were some of those key qualities that you wanted to make sure were in your business plan and that the patients that you were eventually going to provide services for had?
Great question. Well, one of the statistics that you can find on the CDC website is in the United States, there's about 50,000 vaccine preventable deaths in the United States annually. Give or take 10,000 this way or that way. That's more than died or equal to the number of people that died in the Vietnam War. It's not an insignificant amount. So, and a lot of that has to do with lack of adult vaccinations. And so we really want, as a mission, wanted to impact adult vaccinations. Now, post-COVID, everybody's like, of course, adult vaccination. But 2009, it wasn't that. I joke that we were a COVID company before COVID hit, but that's probably why, because, we wanted to focus on adult vaccinations, and we wanted to get into every sort of book of business that adult vaccinations were in, whether it's travel medicine, student health, employee health, immigration physicals, deployment physicals, and a whole host of other healthcare services that adults need, and general adult vaccination, like getting caught up on your pneumonia, zoster, Tdap as an adult. So our mission originally was to do that, and we decided to do that at the exclusion of doing primary care and urgent care, because there would be a strong temptation if you have a whole clinic there, you have doctors, nurse practitioners, RNs, you got exam rooms, and somebody walks in with a sore throat. The temptation is what? The temptation is like, oh, well, let's just see them, right? And then your waiting room's full of people with sore throats and migraines and what have you. And so we wanted to see if we could come up with a model that just focused on preventative health. And then besides the vaccine, we decided to give everything that the person would need in addition to the vaccine. So some of the student starting nursing school or pharmacy school, they needed a vaccine, but they also needed a titer or drug test. Whatever they needed, we would also provide that. So we then went vertical and horizontal, everything to do with adult vaccinations at the exclusion of primary care and at the exclusion of urgent care or workman's comp.
What about collaborating and providing that information maybe back to the employer, right? You mentioned employee health, vaccinations, schools, people are going to medical school, undergrad, you have to check the boxes off. How do you guys do that? Like
wow, that you teed that one up perfectly, because what we have done is we actually wrote our electronic health record like a CRM. Remember, because we have that luxury. And for the employer, for our big employer groups, one of the biggest challenges in employee health is managing employee health records. So let's say you're a hospital right now, and JCO shows up and says, let me see the TB skin test on everybody in the radiology department. How do you do that? Most hospitals, Excel spreadsheets, but what we did is, with any company that signs up with us, we give them backdoor access in a cloud-based fashion to our electronic health records. When their employees come in, they sign a consent that my employer can have the result. Okay, so we get permission, and then they get tagged and get put into the employee portal. So, and certainly for a big enough employer, we will actually custom make their dashboard. So if they want to see everybody in the radiology department that got a flu shot the last 12 months, or who got a flu shot and a TB skin test, or got an MMR. So we become their data management software solution, as well as then providing those healthcare services.
Dr. Baktari, as you look towards your long-term plan of E7, right? You mentioned quick, fast, and easy, 3 great qualities that, of course, patients all over the world are looking for. How do you balance doubling down on those strengths that you just mentioned versus trying to expand and develop and get better at maybe some of the other things like accessibility? As a leader, an emerging leader in the field of digital health, I'm sure that's something, we all got to think about competition and got to think about how to kind of give the best services that we can. How do you balance that out?
So could you rephrase that and balance the...
Sure. The thought of really focusing on the quick, easy, fast, right? Doing the things that are working versus continuing to develop maybe some of the weaknesses, and maybe it's accessibility and some of the things that aren't quite developed yet with E7. How do you focus on becoming a...
I think the patients see quick, easy, and fast.
Okay.
We see on the inside, we see quality, reducing errors, providing patients access to what they need, reducing friction for my staff.
Mm-hmm.
The byproduct, if you're on the outside looking in, it looks like quick, easy, and fast. But that's just a byproduct of focusing. For example, if my staff, there was another statistic that I saw in a typical primary care office visit. And I actually brought this up on my podcast last year. I believe 70 to 85% of the time, and I have to look this up, a clinician is looking at a computer during a primary care visit. Okay, because of our technology, we've got that down to a bare minimum, because everything auto-populates, everything the patient fills out. We, instead of giving instead of giving a clipboard, we actually have 4 computer terminals in the waiting room. So if you didn't register on your cell phone and fill out everything, and the fill out form changes depending on what kind of services you're asking us to do. So that goes to my staff so they see it ahead of time. And so what we've tried to do is we've tried to not only make it quick, fast, and easy, but high quality, follow CDC guidelines. That, we follow guidelines that are actually implemented into our software. So if you need 2 vaccines that are contraindicated, the system won't even let my staff give it to you. If you listed an allergy or anything that might cross-react, but the system will block it. So we're spending all our effort, not on quick, easy, fast. We're spending all our efforts on high quality, protecting the patient, and reducing work for my staff so they can focus on the patients.
Gotcha. Yeah. Let me dovetail on that too. You mentioned about how physicians are, constantly staring at a computer screen. I'm guilty of that too as a resident, trying to be efficient as possible. Artificial intelligence is obviously making a big impact when it comes to things like deep scribing or radiology. Where do you think AI can make the biggest impact for us in healthcare?
Yeah, that's a loaded question because it's really evolving as we speak, right? No, I actually personally think this ability to get access to a library of information by just asking the right question or serving up the right thing. You guys are way too young to remember the Washington Manual, which is like a little spirally book that we always used to carry on when I was training, right? And that used to be, your thing to look up everything. And but to have that served up where you can literally ask any question or present any situation and get the differential diagnosis on anything at your fingertips, even more so than Google, and presenting a scenario of situations, and it can only improve quality in patient care. I'm super excited about that, beyond belief. I think talk about changes in medicine that will really save lives, improve quality, and I'm very excited about it.
Awesome. Dr. Baktari, I have a question, and maybe this is a little too personal, but I do want to get a sense of what advice would you give to somebody really close to you who's maybe thinking about entering the medical field, right? So they're freshmen in college and they're like, oh yeah, I'm really interested in medicine. And maybe it's your son, maybe somebody really, really close, and you're invested in their future success. How would you advise them to tread this field that's at the cusp of evolution, but we just can't seem to quite get there? Like, we've had excitement for such a long time for a lot of these topics, we just can't seem to figure it out. It's always slower, right? I think what's a stat that when we learn something in medicine, it takes somewhere 12 to 17 years for us to actually implement it in practice, which is preposterous, right? Yeah, what advice would you give?
I think it depends what attracts you to medicine, because I think medicine has maybe 2-3 broad categories of just, there's so many things, but if you had to pick big, issues or things that are draws, some people, it's a calling from God. They want to help people, and this idea of there are very few professions in the world that give you the privilege of impacting people's lives, like healthcare. Like, it's unbelievable, and you should consider it a privilege. That's not, birthright. I mean, just a handful of people in this planet are given this opportunity, and you got to view it like that. So if you're viewing, if that's your motive for going into healthcare, it's the best field in the world. I'm so lucky to be a part of it, and I'm so lucky to have partaked in some of that, and it's a true privilege. If also part of the reason, in the past, people used to equate being a physician as having autonomy, and, running your own show, and, making your own decisions, and, not having someone second guess your decisions. I think that has become less and less true, right? I mean, you will have somebody at the HMO second guess your decision for an MRI, and you will have, if you're in a group or an employee, hey, they're going to look at your metrics, how many CAT scans have you ordered versus someone else. And so I think if the lure in my generation was a combination, I get to have this privilege, but I'm also, I don't want to work for someone, and I want to have this autonomy. That's pretty much gone or going. So to not totally answer your question, but to split the thing in half. If your motive is, this is a calling from God and a privilege, yes, there is no better field. If part of your motive is, I don't like people telling me what to do. I want to be smart. I want to be intelligent. I want to take care of my own patients, and I don't want anyone second guessing me. When I say everyone can be second guessed, but I don't. I think I'm entering a field that has that autonomy, and that's probably not going to be true. So I would sit down with that person and understand which one of those two is more important to them.
So let's take that first person, right? Because I think that gives us all the feels, right? It gives butterflies in our stomach. And as altruistic as the reason might be, they're still going to experience all the same frustrations that we've talked about in the first half. Mm-hmm. They're going to see the barriers. And a lot of people, I'm willing to bet more than, I don't have any data to support this, but I just anecdotally, I would say more than 70% of the people are going in because some sense of altruism and they want to help. You have to be somewhat special in that sense. You have to have some sense of compassion and empathy for somebody else's pain in order to go into this. Otherwise, why would you subject yourself to all that training, all that time wasted, sacrifices that we make? Yet when you get to that end of the tunnel, as Darsh and I spoke about not too long ago, you realize, oh man, this is different. This is not quite what I wanted. You can still have the same motive that you've highlighted, right? Mm-hmm. I'm wondering, again, this is the person that you're deeply invested in their care, right? So that's why I said maybe it's a child of yours. What tactics might you suggest so they're less likely to be not burnt out, but turned off? So that fire that was the reason for them to go, that motive isn't dampened over time, that they're still invigorated 10 years in, 5 years in, 20 years in.
Right. It's a complicated question because, look, every industry has their own headaches and issues, right? You've talked to attorneys, you talk to investment, they're all going to say my industry is this. So look, there's no perfect industry that, it's clear sailing as soon as you get into it. In insurance business, they have issues and what have you. So I don't know if we can get rid of that. I don't know if the frustrations in medicine are a lot worse or better than any other industry per se. I think what has changed is the autonomy and maybe the upside potential financially, if that was important to someone. Clearly, if you're going to be an employee, there may be more stability, although I'm not sure about that, because when corporations get bought out and they decide to close this and open that, but there's potentially a sense, and you get a 401k and what have you, which many of us did not have, at least from an employer. So you get more security, maybe more benefits, and maybe less burnout, because some of these jobs are more 9 to 5, and you're not, because it's not your practice. You're not working 80 hours a week like some people do when they start their practice. So I think the burnout is probably going to be less. And the headaches aren't yours. If the receptionist quits, you're not going home and losing sleep about it, because you don't, whatever. That's just like, the HMO will have to deal with that, or the PPO, or the healthcare system, the hospital will have to deal with that. So one of the functions of being employed is some of those headaches go away. And so I think there will be less burnout and less headache and less stress. So I guess you consider that a positive of some of these changes, right? Because you can literally clock in and out, do your shtick and move on. Your long-term upside is going to be somewhat limited by that, but you may be okay with that.
Yeah, one of the quotes that I'm starting to love more and more is that there are no such thing as solutions, only trade-offs, right? And the more I talk to people from other industries, like you said, law, dentistry, you start to see that it's not just us in medicine that are special. I mean, everyone's got some short end of the stick that they're pulling out in their industry. So, but again, I think what you said is very valid, on point. You hit the nail on the head. That there is just a lot of gray area, and as Altamash talked about, hopefully we can be optimistic as the next generation comes on and tries to take healthcare in their own hands and is able to provide better services with better quality of care, with obviously money on mind, which is the bottom line, kind of dictates everything right now. But Dr. Baktari, I just want to thank you. I think our listeners, this is obviously a common theme that we talk about on our podcast, right? Medicine Redefined is about how do we redefine this conversation. And I think you did a great job today talking about digital health, what it actually means. I know I learned a lot, gave me new perspectives as well. So I just want to thank you for that.
Thank you. Thank you. That was fun.
Yeah, absolutely. So what is next for you? What's next for E7? What do you have in mind and where do you want to take it?
Well, so E7, we're once we really are comfortable with making all our technology scalable, is to expand regionally and beyond. But in the meantime, we're growing e-national testing, which is our nationwide platform where people can order laboratory testing at 2,000 plus locations. Really, it's just with a few clicks and get the result online. So that's our two-pronged approach for the future.
Very cool. Very nice. Yeah. So we're excited to definitely see how that all unfolds. And again, a leader in the field of digital health. Awesome. So where can our listeners find you? Any social medias, any websites that you want to plug in? We'll definitely link these in the show notes.
Yeah, sure. I have my own podcast, Baktari MD. You can find that on YouTube or on all the podcast platform. The other one, of course, is my website, baktarimd.com. You're welcome to reach out to me on LinkedIn. And of course, our website for our company is eNational Testing and e7health.com. Those two are also, you're welcome to visit. So those would all be great.
Awesome. And then our last question, Dr. Baktari, that we ask everyone, which we pretty much talked about for a while here. So maybe you could spin in a different direction. But how do we add the health back to healthcare?
Yeah, I think it's letting people take control of their own healthcare. What I often see is people feel like they're not participating in their healthcare, that they're almost like bystanders. And I think companies like us and other companies really are making inroads in giving patients more control, whether it's the telemedicine stuff that we're doing, other channels. You feel like you have some options.
Right. Yeah. Well said. Well, Dr. Baktari, I just want to thank you again for everything you educated us on.
Oh, it's my pleasure. Thank you for having me. It's been a lot of fun.
Thanks for listening to another episode of Medicine Redefined. If you enjoyed this episode, please be sure to check out some of the additional resources in the show notes. Please also check out our social media platforms where you can find more content like this. You can follow us on Instagram, Twitter, and TikTok at MedRedefined. We want to take a moment to thank our team for the production of this podcast, specifically Ethan Ju and Haritha Yepuri. Lastly, please remember the important disclaimer that everything in this podcast is for educational purposes only. It does not constitute the practice of medicine, nor should it be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues. However, if you enjoy the show, please be sure to subscribe, review, and share with anyone who you would think will gain value from this as well. Until next time, thank you for listening.